Okay, good day, everyone. Today we are going to be talking about the gross anatomy of the brachial plexus. Okay, now to introduce this, the brachial plexus it's a you know, complex network of nerve that is formed by the anterior, that's the ventral rami of the spinal nerves. So we have the C5, the C6, the C7, the C8, and the T1. Now it functions, the function is to provide motor innervation to the upper limb, provide sensory innervation to the upper limb, supply some muscles of the pectoral region, and then it extends from the neck to the axilla, then into the arm. Now, what are the formation of the brachial plexus? That's the roots of the brachial plexus. The brachial plexus is formed by the anterior rami of the C5, C6, C7, C8, and the T1 nerve. Now, sometimes it receives contribution from the C4. Then we'll say that the brachial plexus is a prefixed plexus. Well, then sometimes it receives a contribution from the T2, then we say it is postfixed plexus. Now, these roots, they emerge between the anterior scaling muscle and the middle scaling muscle. And this region is actually called the interscaling triangle. That is where the brachial plexus emerge from. Now, what are the structural organization of the brachial plexus? The brachial plexus is arranged in 5 parts, okay? It has a root that leads to the trunks, that leads to divisions, that leads to cord, and then that leads to branches. Okay, a common memory guide for this is Randy Travis drinks cold beer. Okay, Randy Travis drinks cold beer. Now, what are the trunks? Let's look at it from the trunks. Okay, we have already looked at the roots. Okay, and we said it can be prefixed or postfixed. Now, looking at the trunks is formed in the posterior triangle of the neck. The upper trunk is made up of C5 and C6 come together to form the upper trunk. The middle trunk is formed by only the C7, it goes. Then the lower trunk is formed by the C8 and the T1. Now, what is the clinical importance of this? The upper trunk injuries, once there's an upper trunk injury, it leads to air palsy. Okay, once there's a lower trunk injury, it leads to Klumpy's palsy. Okay, now let's talk about the division of the brachial plexus. Each trunk divides into an anterior division and a posterior division. There are 3 trunks, remember, so which means that we'll have 6 divisions. Now, normally the general rule is this: the anterior division supply the flexor compartment, that's the muscles of the anterior compartment, while the posterior division supply the extensor compartment. Now, division here, the divisions, they lie behind the clavicle. These are the divisions. Now, talking about the cords are formed in the axilla. They are named according to their position around the axillary artery. Okay, we have a lateral cord, which is formed by the anterior division of the upper and middle trunk. We have the medial cord, which is formed by the anterior division of the lower trunk. Then we have a posterior cord. That one is formed by all 3 posterior divisions. Remember, they are named according to how they are, their position around the axillary artery, which means lateral cord is lateral to the axillary artery, medial cord is medial to the axillary artery, while the posterior cord is posterior to the axillary artery. Now, what are the terminal branches? There are 5 major terminal branches. We have the musculocutaneous nerve, musculocutaneous, muscular, then cutaneous. So we have a musculocutaneous nerve. We have the axillary nerve or auxiliary nerve. Okay, we have the radial nerve. We have the median nerve. We have the ulnar nerve. Remember, MARMU. Now, what are the branches from each part of this? From the roots, there are different branches from different parts. Okay, from the roots, for example, we have the dorsal scapular nerve, which is C5, all right? Then we have the long thoracic nerve. That one has a root value of C5 to C7. Now, the long thoracic nerve, if there's an injury to the long thoracic nerve, then definitely there will be winged scapula. If you remember in my video when I was talking about the pectoral region, I mentioned this. Now, from the upper trunk, we have some branches coming out from there. We have the suprascapular nerve, and we have the nerve to the subclavius. Remember the subclavius muscle? Now, from the lateral cord, we have the lateral pectoral nerve, we have the musculocutaneous nerve, we have the lateral root of the median nerve. The lateral root of the median nerve. And then from the medial cord, we have the medial pectoral nerve, we have the medial cutaneous nerve of arm, we have the medial cutaneous nerve of forearm, and then we have the ulnar nerve. Then we have the last one called the medial root of the median nerve. What about from the posterior cord? We've not mentioned it. From the posterior cord, we have the upper subscapular nerve, we have the thoracodorsal nerve, we have the lower subscapular nerve, we have the auxiliary nerve, and we have the radial nerve. Now, what are the causes of this nerve? Because it's not just enough for you to know, the names of this nerve. As a good anatomy student, you should be able to also know their cause. Now, in the neck, the roots and trunks, they lie in the posterior triangle of the neck. Behind the clavicle, we now have the division. While in the axilla, cords surrounds the axillary artery, if you remember very well. But in the arm, terminal branches follow their respective compartment. Whichever one is going to the anterior compartment, whichever one is going to the posterior, they all go. Now, what are the relations of this nerve? Now, closely related to this nerve, we have the subclavian artery, we have the axillary artery, we have the clavicle, and of course, we have the first rib. Compression can occur in the thoracic outlet here, okay, and a lot of things can happen. So now let's talk about the clinical implication of this. Abductional palsy, that's the upper trunk injury. Okay, this happens once there's an injury to the C5 to C6 root. Okay, and common cause of this is birth injury, or when someone falls on their shoulder. Okay, it can happen. Features of this is the arm is abducted, okay, ADD, okay, medially rotated. There's an extended elbow, and of course, there's also a pronated forearm. So it leads to what we call the waiter's tip posture. Waiter's tip posture, okay. Then we also have what we call the clump case palsy. I already mentioned this also, the lower trunk injury. This is an injury to the C8 and the T1. Of course, the common causes of this is when someone is pulling something, or someone try to fall and break a fall, so it can happen. So there's also cervical rib compression. Once the cervical rib compression, it can also happen. The future of this is that there will be claw hand, and of course there will be intrinsic muscle paralysis. Then also I mentioned a particular nerve called the long thoracic nerve. Remember I said that okay, so the long thoracic nerve can also be injured, and causes can be probably mastectomy or even trauma. And remember, I always mention this, it results in the winging of the scapula. Okay, then what happens when there's a radial nerve injury? The radial nerve injury in the mid shaft of the humeral fracture results in wrist drop. The wrist will just drop. The surgical importance of this is that it's actually used for nerve block, that's interscaling block. That's the surgical implications of the brachial plexus. Auxiliary surgeries and even trauma assessments can also be an advantage of this. Now there are functional organization of this, okay, more like a summary. Remember, anterior division goes to flexors, flexor muscles. Posterior division goes to extensor muscle. Lateral cord is mostly flexor of the arm. Posterior cord, remember, is to the extensors. Then medial cord is intrinsic to the hand muscle. Remember, the medial cord is mostly intrinsic to the hand muscle.